Hello, I'm Dr. Gregory Waryasz. I'm an assistant professor at Harvard Medical School and faculty at Mass General Brigham in the Division of Foot and Ankle Surgery and Sports Medicine. And I am honored today to have a great webinar set up through Arthroschool for female athlete artist foot and ankle injuries. We have faculty from around Mass General Brigham, multidisciplinary, to attack this difficult topic. We're going to be starting off with Jeremy Smith, who's a foot and ankle surgeon at Mass General Brigham, talking on sex differences in sports foot and ankle with surgical treatment considerations.
Jeremy T. Smith, Orthopaedics from Mass General Brigham, will present sex differences in sports foot and ankle, surgical treatment considerations.
Hi, everybody. My name is Jeremy Smith. I'm excited to be talking to you today about sex differences in sports foot and ankle, surgical treatment considerations. So first off, I thought I'd address the question of what is sports foot and ankle specifically. This is something that I do a fair amount of. I think of this in two ways. So first off, it's defined by which patients. So we think of athletes as being sports foot and ankle patients. But also those that maybe were injured during sport, but aren't necessarily under the title of athlete or desiring a return to sport. And it's also defined by what problems. So another way to think about it is problems such as ligament injuries, tendon injuries, cartilage injuries, or fractures in athletes. These are things that tend to define sports foot and ankle. Some of the things that we see in sports foot and ankle are treated with surgery. For example, certain ligament injuries, such as chronic lateral ankle ligament instability, can be treated with surgery. Certain tendon injuries, like Achilles tendon rupture, certain cartilage injuries, such as osteochondral lesions, are sometimes treated with surgery, and certain fractures, like unstable ankle fractures. There is, of course, variability between the sexes when we think about the pathology of things we see within sports foot and ankle. I've noted here some of those. So females in general have a higher rate of lateral ankle sprains, as well as a higher prevalence, accordingly, of chronic ankle instability. And associated with that, and I'll talk about this some more, is a higher prevalence of peroneal tendinopathy, a higher incidence of stress fractures, hallux valgus, which are bunion deformities, are more common, and there are fewer high-energy sports-related injuries in females. In the U.S., that may be in part related to less contact sports such as tackle football. From an anatomic standpoint, there are variabilities or variations between men and women, and females tend to have increased physiologic valgus alignment at the knees, which can lead to a higher prevalence of pes planovalgus, so that means a flatter foot, so that's more common in women. There tends to be greater hindfoot flexibility in females and increased first ray mobility, which tends to be defined by motion at the first tarsometatarsal joint. And this can contribute to and be associated with the higher rates of sprains, ligament instability, and then hallux valgus, again, that being bunion deformities. From a physiologic standpoint, this is in part due to hormonal influences on ligaments, including the estrogen relaxin effects on ligament properties. And there are also associated potential effects on tendon stiffness and neuromuscular control. The evidence for menstrual cycle influence on ligament properties is mixed, but this may also contribute these factors to the increased prevalence of sprains, ligament instability, and hallux valgus. From a physiologic standpoint, we also have to think about hormonal influences on bone, not just ligaments. So things such as RED, so relative energy deficiency in sport. So that's where inadequate caloric intake can lead to reduced estrogen and testosterone, leading to this triad of low energy availability, menstrual dysfunction, and decreased bone mineral density, which can lead to a higher risk of fragility fractures, such as stress fractures, and potential bone density problems with fracture fixation, which I'll talk about more in a moment. So when we're thinking about surgical considerations, which is really supposed to be the intent of this talk, there are a few things I wanted to address. So the first is when we're treating patients with ligamentous laxity, we need to think about and consider the integrity and the quality of the ligaments that we're repairing. So in patients with lateral ankle ligament insufficiency, that is where the lateral ligaments are not supporting the ankle adequately. In these individuals, particularly women, I think it's really important to evaluate for generalized ligamentous laxity. And we use a scoring system called the Baton score, which looks at a number of different sites of ligamentous laxity and joint hypermobility. Shown here is this individual, this woman, putting her thumb against her forearm, which I, of course, cannot do, but she certainly can. And if in those who have generalized ligamentous laxity, we may consider an augmented ligament reconstruction as opposed to using the native ligaments alone. So what does that look like? So there are different techniques for this, but in general, the Brostrom or the Brostrom procedure has historically been the most popular repair technique, which is an anatomic repair of the ATFL and the CFL ligaments. Now we can augment a Brostrom with various materials, including suture tape, which is this braided suture material, and tendon graft, which is where we weave a tendon through the bones to augment the native tissues. And this is what that looks like in a cartoon here, where we're replicating the course of the ATFL plus minus the CFL with a suture tape material. And this is to augment the native tissues if they don't have adequate integrity. Technique tips for this: I think it's really important to check the position of the anchors in the talus bone and the calcaneus if you're augmenting the CFL as well. We're trying to anatomically replicate the anatomy of the native ligaments with these grafts or with these suture tape. And so it's really appropriate to or necessary to appropriately tension the grafts and get the anatomy right. And important also to assess for subtalar joint instability, not just ankle instability. And if needed, we can bring a limb of the augmented reconstruction down to the calcaneus to replicate the course of the calcaneofibular ligament. We can also use tendon grafts as needed. And there's listed here, I won't go through all this, but different types of tendon grafts that can be used. Again, these are intended to augment in the situation of generalized ligamentous laxity when doing surgery for chronic lateral ankle instability. And this is what that looks like in a patient here, where we've used tendon graft to weave through, to augment, and to replicate the course of the ATFL and the CFL. I mentioned that females have increased rates of perineal tendinopathy, which is likely associated with ligamentous laxity. And I think it's really important because of this to evaluate the perineal tendons when evaluating patients with lateral ankle ligament instability or lateral ankle pain. That can be done in several different ways: on physical examination by palpation of the site of pain and circumduction to see if there's perineal instability, and also with imaging. That can be done with ultrasound or with MR. And I think it's important to consider addressing the perineal tendons if there is pathology within the tendons at the time of ligament reconstruction. You can often visualize the perineal tendons at the time of your ligament reconstruction, and that can be done using open techniques or tendoscopically, where we look within the tendon sheath with the arthroscope to evaluate for perineal tendon pathology. I'm going to speak next about stress fractures and how we think about these injuries. Critically, it's essential to evaluate the underlying cause of the stress fracture. So we want to screen for REDS. We want to consider an endocrine workup, including evaluation of vitamin D and also PTH and TSH, and also thinking about nutrition. And there are various nutrition labs, which I've listed here, which is not comprehensive, but we want to try to understand the cause of the stress fracture. Is it mechanical? Is it nutritional? Is it endocrinologic? What is the cause? And because it's really critical to address the underlying cause in addition to providing the appropriate orthopedic treatment. We think of low-risk stress fractures as being calcaneus, cuboid, cuneiform, and lateral malleolus stress fractures of the foot, whereas high-risk stress fractures within the foot and ankle include medial malleolus stress fractures. The majority of stress fractures are treated without surgery, but there is a subset, and these are some examples of patients of mine who have undergone surgery in certain scenarios where either they haven't improved or they have a high-risk stress fracture, such as this first metatarsal fracture, which was persistent despite non-surgical care, this navicular stress fracture in a 33-year-old tennis player, and a 21-year-old collegiate basketball player with a fifth metatarsal base fracture treated with surgery. So really critical to understand the underlying cause in addition to appropriately treating these fractures, often without, but sometimes with surgery. I'll speak for a minute about bunions as well, much more common in women than men. Bunions can create problems with shoes related to rubbing. This is particularly relevant in athletes due to tight fitting footwear. So certain cleats, for example, are going to be generally, athletes prefer to wear tighter cleats in soccer as a good example. And in the presence of a bunion, this can be really challenging. We always try non-operative care in our athletes and in the general population. This includes things like stretching the cleat or the shoe and trying various bunion sleeves to provide padding or a toe spacer to help realign the toe while it's in the cleat so it doesn't rub or in the shoe. And I think it's really critical to counsel patients carefully before proceeding with surgery. This is really relevant in athletes because the demands are so high. And so in women primarily, or men undergoing surgery for bunions who are athletes, it's really important for them to understand that they may or may not get back to their sport at their pre-surgical level. And that guides the decision-making algorithm about whether surgery is appropriate or not. And that's really important to have those conversations before surgery. This is an example of a 30-year-old competitive figure skater who I took care of, who had this hallux valgus deformity and could not get in her figure skate without substantial pain at the medial eminence of her medial forefoot. And she underwent a minimally invasive bunion correction shown here and has done quite well. And so it's important to counsel her, as I did, that she may or may not get back to competing at the same level just due to the uncertainty of the recovery and the duration of recovery. Ankle fractures. With all ankle fractures, it's important to gain an anatomic alignment. In athletes, and including women, it's critical to consider lower profile implants. So we don't want to put plates and screws in there that are going to be so prominent that it's going to make it difficult to wear the necessary, whether it's a hockey skate or the necessary equipment for sport. We want to ensure fixation is adequate for those with lower bone density issues. And then with all our athletes, there's a really important collaborative rehabilitation that involves athletic trainers, physical therapists, and it's also important to counsel patients about return to play. So these are two operative ankle fractures in athletes that have a very different personality. On the left here, this is a much lower energy rotational injury versus a higher energy comminuted ankle fracture, and it is going to be much more challenging for the individual with the radiographs on the right to get back to sport just because of the magnitude of the injury. And in those radiographs shown, so a 24-year-old professional a soccer player shown here with surgical fixation versus the skateboarder shown here who had a different construct, but nevertheless still surgical fixation of an ankle fracture. And hopefully both these young female athletes will get back to competing, and we will see. So key takeaways. So female athletes have higher instability and stress injury burden than male athletes for the reasons that I mentioned. We want to think about laxity and alignment issues as those often influence our surgical decisions in terms of optimizing our surgical treatment plan. We want to consider and address bone density issues, endocrinologic, nutritional. It's really critical to get to the origin of the problem, and successful outcomes require attention to systemic factors, not just the orthopedic care that we put a lot of thought into providing. So that's what I've got. Thank you very much, and thanks for your attention.
Thank you, Dr. Smith, for a wonderful talk. We're going to jump ahead to Dr. Lauren Elson for non-operative management of the foot and ankle and special considerations for the performing artist. Very excited to hear this discussion as she's one of the world experts in dance medicine.
Lauren E. Elson, Physical Medicine, Rehabilitation from Mass General Brigham will present non-operative management of the foot and ankle, special considerations for the performing artist.
Hi, my name is Lauren Elson, and I'm happy to talk to you about my favorite topic, which is treating performing artists, and in this case, unique injuries to female performing artists and within the foot and ankle. The first thing we're going to start with is understanding the similarities and differences between treating our performing artists and athletes, and then looking at the biomechanics, especially more skewed towards women, that contribute to the dance-related injuries, as well as to the treatment considerations in this population. My talk is going to skew a bit more towards the side of ballet, just given the short amount of time that we have, but we could go into lectures on each genre within this. Just like athletes, dancers develop pathologies related to load and load-bearing capacity. In an average ballet class, the dancer does over 200 jumps with more than 60% of those on a single leg. Also, dancers tend to work at extreme ranges of motion and in footwear that the average population does not wear on a regular basis. Dance also skews, especially within the ballet realm, to a more lean physique. And we see a lot of consequences with this that lead to disordered eating and underfueling, which in turn lead to issues with healing injuries. Dancers also tend to not cross-train as much as they should. So while we think of them as generally fit, they actually have a lot of muscle imbalances very frequently, and also tend to specialize earlier than in other sports. Just like other athletes, the dancers' bodies are very fine-tuned, and we have to appreciate the psychological impact of injuries and also think about how we're going to get them back to dance after an injury. And unlike an athlete where you can send them all taped and braced and you can tell them to go do something at 50%, a performing artist can't do that because they're actually playing a specific role and trying to get an emotional response from the audience. So they have to be 100% to go back in. Dancers also tend not to seek out medical care if they think they're going to be told to stop dancing. So because of that, we don't see a lot of the acute injuries. We see things that are more lingering and that are more causing other issues. When there's a study that looked at young dancers and what they were hoping to accomplish, a lot of these are not as related to foot and ankle, but one of the things that they do seek out are trying to get perfect arches or gorgeous arches in their feet, and they will often use these tortured devices or contraptions to stretch their feet passively, which we know that can create more hypermobility in hypermobile dancers and also don't facilitate the strength that we're looking for within the feet. They also try to achieve perfect turnout, and even though we think of that as more a hip issue, we'll talk about how that affects the feet. And also, as I mentioned earlier, that lean aesthetic. If they are under fueling, then they are more likely to develop stress fractures and to take longer to heal. Dance injury rates are high, and when we look specifically at the dance population, they tend to have more overuse and chronic injuries than acute injuries, and ballet dancers tend to have more foot and ankle injuries, in some studies over 50%. So we'll get quickly into this biomechanics of dance-specific injuries. First is just thinking about the shoes, and Emma later is going to talk about some of the common specific diagnoses that we deal with, but when you kind of take a look at all the different types of shoe wear that a dancer may come in with, especially our ballroom dancers in heels, our ballet dancers in pointe. Also, many of our contemporary dancers don't wear shoes at all, so that impacts the types of injuries that they're going to get. We also have to take into account how they're training. If they're training in a new type of shoe, we recently treated a tap dancer that was switching brands to accommodate a show and ended up with a compartment syndrome in the foot related to that. The age of the shoe is related, and also we can't treat them with orthotics in most of these shoes because there's just not enough room. I mentioned earlier that the dancers are often trying to achieve 180-degree turnout at their feet, but often when they're forcing this, if they're not using natural turnout, they end up with a more pronated position. And so you can see here this dancer is standing with her feet in this more pronated position, which makes her more at risk of certain types of tendonitis and ankle pain, as well as foot and ankle impingement syndromes. Whereas this picture on the bottom here is with good biomechanical alignment. A lot of performing arts subspecialties, including aerial artists and ballet dancers, tend to self-select for the hypermobile population. But one thing to consider is that when a dancer is trying to achieve balance, their base of support needs to be over their center of gravity needs to be over their base of support. And so if they're hypermobile and they have more than a straight line through here, they're going to need to have an equal amount of hyperextension in their knee as they are with a hyperplantar flexion of their foot. And if they don't have equal degrees here, if they're not supported, they're going to end up with knee or foot injuries. Hypermobile dancers also tend to come in with subluxations of their cuboid and also anterior ankle impingement syndromes related to hypermobility of their ankles, often from standing in this exaggerated record bottom in their knees. We see a lot of injuries related to point, especially with dancers who are not ready to be going on to point or going too early, or are not strengthening the muscles in their feet correctly. So we'll see a lot of posterior impingement syndromes, symptomatic ostrigonums, and posterior tendon irritation. The flexor hallucis longus, or we call that dancer's tendinitis, tends to be a very common diagnosis in this population. Also, if the dancers are not ready to go on point or don't have the flexibility, they'll cheat and go into more of a lateral weight bearing, and that increases risk of lateral ankle sprains and lateral ligament overloads. When we're treating the dancer, we need to identify the anatomic diagnosis, but also treat the impairment. Because if we aren't fixing the whole problem, then they're going to come back with either recurrence of the same injury or other compensatory injuries. This is really a teamwork approach where we can intervene with adequate nutrition, address the psychosocial factors, as well as advocate for safety. When we're dealing with dancers, we never tell them what we're restricting. We always tell them what they can do. Because if you just tell them to not go to class for 3 weeks, they're not going to listen to you. But if you tell them they should go to class and maybe not participate, but they can do floor bar, or they should be doing work at the bar on flat but not in releve, or to limit their jumps to double leg instead of single leg, we can really control how they get back. Also, dancers tend to mask their symptoms with NSAIDs, so cautioning against that and really only using the NSAIDs for short periods of time when they're not pushing their activity levels. We're also very limited in our in-season interventions, but we can apply taping and padding, as well as work on the myofascial component of symptoms, including dry needling and trigger point injection. Shockwave has been a game changer in terms of treating pain and not having to pull people out at the same time. It is very, very rare that I will consider a steroid injection for a performing dancer because of the long-term consequences and usually the more subacute nature of the injury. So in summary, performing artists, especially female dancers, tend to develop injuries related to the specific demand. So very often that extreme range of motion and the hypermobility, as well as the demands of their art. And rehabilitation really requires looking at that whole kinetic chain, as well as a dedicated team. Thank you so much.
Thank you, Dr. Elson. That was a wonderful talk. We're moving on to Dr. Nicole Katz, who's faculty in our sports medicine, physiatry group at National Brigham.
Nicole B. Katz, Physical Medicine Rehabilitation from Mass General Brigham, will present sex differences in the non-operative treatment of foot and ankle.
Thank you so much. As you heard, my name is Nicole Katz, and I'll be presenting sex differences in the non-operative treatment of foot and ankle sports injuries. So I have no disclosures. Let's start with identifying the real problem. Only about 1 in 6 foot and ankle studies in high-impact journals perform any sex-specific analysis. And of the studies that did look, 30% found significant differences in the outcomes. Notably, female athletes may be carrying more of this injury burden. In a large Division I cohort study, they found the 4 sports with the highest foot and ankle injury rates were all women's sports. And across sex-comparable sports, women have a 1.25 times greater risk of foot and ankle injury and a 3.4 times greater risk of bone stress injury. Looking at lateral ankle sprains specifically, we published in PM&R Journal last year, looking at the representation of women specifically in lateral ankle sprain research. Women have nearly double the incidence of lateral ankle sprains, yet across 77 studies and over 10,000 participants, women made up only 41% of the research participants. And this has not improved over the past decade. The clinical implication here is that our non-operative treatment protocols for one of the most common injuries in sports are built on evidence that underrepresents the population most affected. Let's talk more about ankle sprains. Female sex has also been identified as an independent risk factor for acute ankle sprain. National data from 2010 to 2024 showed higher incidence in women and notably an earlier peak, ages 10 to 14 in girls versus 15 to 19 in boys, which matters when we start thinking about prevention. The core non-operative management is the same, with early weight bearing, functional bracing, progressive neuromuscular rehab. What differs, though, is the risk trajectory. Given the higher rate of progression to chronic instability that Dr. Smith mentioned earlier, one could consider having a lower threshold in our female athletes for prolonged neuromuscular training and even extended external support. And we do have data that prevention works. So the 2025 FAIR consensus found that neuromuscular training reduced ankle sprains by 39% in female athletes, with a minimum dose of 10 minutes twice a week. There's 3 additional conditions I want to highlight specifically in this content. So Morton's neuroma, more than 4-to-1 female predominance. For treatment, we start with the wide toe box, metatarsal padding, footwear modifications. If injecting, we use ultrasound with data showing that that lasts longer and more accurate than palpation-guided injections. For plantar fasciitis, we have a higher prevalence in women, and biomechanically, women demonstrate greater plantar aponeurosis strain during landing, with treatment being stretching, foot core strengthening, orthotics, and shockwave as well. We've also seen really interesting data on ultrasound-guided PRP injections for recalcitrant cases. For Achilles tendinopathy, there's no overall difference really suggested in the literature as far as prevalence, but there is one in the treatment response. So if a woman is 12 weeks into her eccentric training and loading protocol and she's plateauing, that may actually be an expected trajectory rather simply a non-adherence or an issue with how it's being performed. And that's the time when you should really consider adding another modality such as shockwave or tenotomy rather than repeating the same prescription. The data discrepancy I talked about for lateral ankle sprains isn't unique there. Roughly 70% of our sports medicine studies isolate male athletes, while fewer than 9% isolate female athletes. And critically, only about half the studies that include both sexes actually analyze sex as a variable. That being said, when we do look at the differences, we often find real differences. So regarding chronic ankle instability, up to 30% of acute ankle sprains progress, and women are at a higher risk. For Achilles tendinopathy, as we alluded to earlier, after 12 weeks of eccentric training, women improved their Visa A scores by 20% compared to 27% for men, with the same protocol but a different responses being seen. For plantar fasciitis, there's a roughly 2.5 times higher prevalence in women with an adjusted incidence rate ratio near 2 in the military data. So the bottom line here is similar as before, which is that we're frequently treating female athletes with protocols that are developed largely in male populations. But when we actually measure and look for sex differences, we often do find them. Point-of-care ultrasound has been suggested to be a really game changer when it comes to foot and ankle injury management. So both as a diagnostic as well as a management tool. So ultrasound-guided injections have been suggested to be more accurate, more efficacious, and also more cost-effective than landmark or palpation-guided. So a few high-yield applications I want to highlight. So Morton's neuroma we talked about previously. Again, this is a 4-to-1 female predominance, with data showing that ultrasound-guided steroid injections outperforms non-guided injections at 12 months. For plantar fasciitis, where ultrasound-guided PRP injections show superior pain as well as function improvement compared to steroid at 6 and 12 months. And then Achilles tendinopathy, which is the condition we talked about where there's a different response between men and women for eccentric strengthening, where percutaneous ultrasound-guided tenotomy gives durable improvement at a 1 year. And dynamically, ultrasound has also been shown to be very valuable for peroneal tendon subluxation, which a static MRI might miss. Shockwave therapy also has a role in the treatment in foot and ankle injuries. For plantar fasciitis, there's really strong evidence for this for both pain and function, both the short and the long-term effect. And there's some really interesting evolving data looking at shockwave therapy for Achilles tendinopathy. And this is really what belongs here in this slide is that a recent work showed that 88 runners with Achilles tendinopathy had an MCID achievement that was similar between the females and the males. But we did find a signal which was hormonal, where females that were on oral contraceptive pills were significantly less likely to meet MCID than females that were not on OCPs. Bone stress injuries, you've heard a little bit about from our two prior speakers, but whenever you see a foot bone stress injury in a female athlete, this really should trigger a screen for energy deficiency. Whether one uses the female athlete triad framework or REDS, relative energy deficiency in sport, a bone stress injury in trabecular-rich bone, such as the calcaneus or the navicular or multiple bone stress injuries, should really trigger a clinical evaluation for screening for menstrual function, energy intake, disordered eating, prior bone stress injuries as well. And often will include involving nutrition and mental health care early on. For athletes whose bone stress injury stalls despite some load management as well as nutritional correction, shockwave is also a reasonable non-invasive option. Briefly, I also do want to discuss the hormonal aspect that Dr. Smith alluded to earlier too. A recent systematic review of foot and ankle biomechanics across the menstrual cycle found that in the ovulatory phase, women show arch collapse and an increased foot length, reduced fascial thickness, lower tibialis anterior and peroneus longus stiffness, and a greater postural sway. Relaxin 2 also correlates with the anterior posterior ankle laxity in the luteal phase in women with recurrent ankle sprains. We previously also showed the Achilles tendinopathy response with shockwave might also be impacted by the use of oral contraceptive pills. So this evidence overall is really still evolving. It's very new, but really early, but it suggests menstrual cycle may eventually be a variable in how we time and dose both treatment as well as prevention. I want to leave us with 5 key takeaways here. The research gap is real and it's not closing. We need more data on female athletes with foot and ankle injuries so we can learn best how to treat. Only about half of the mixed sex studies analyze sex at all, so we're missing differences that are existing. Female athletes are at a higher risk for chronic ankle instability. Every foot bone stress injury in a female athlete should necessitate consideration of screening and looking at energy deficiency. And when conservative care fails, considering non-surgical interventions, including ultrasound-guided injections and shockwave therapy. Sex-informed care of the foot and ankle requires multidisciplinary care, so I'm really grateful we had this panel to talk more about that all together. Thank you.
What a great review, Dr. Katz. Thank you so much for that. We're moving on to start talking about rehabilitation with Dr. Emma Nelson, who's one of our faculty physical therapists in the Mass General Brigham Spalding system. So thank you.
Emma Nelson, physical therapy from Mass General Brigham, will present sex differences in foot and ankle rehabilitation for dancers.
Hi, my name's Emma. I am a physical therapist here. Physical therapist here at Spalding, working mostly with dancers, performing artists, circus performers as well. So we're going to talk about the sex differences in the foot and ankle rehab for dancers specifically here. When we look at foot and ankle injury rates in dancers, we do find that that is the most frequently injured body part, and we find that it is higher in females versus males. So I think here in the rehab world, we then want to ask, well, why does that happen? When we look at dance across many disciplines, we recognize that you're working in these kind of high impact end ranges of motion, regardless of if it's ballet, if it's contemporary, ballroom, Irish step dance. And then female dancers in those genres are often in footwear that puts them into even more plantar flexion, which we'll talk a little bit more about, which can put them at a higher risk for some of that injuries. There's also the thought that females may just be reporting these injuries more than males. As Dr. Elson alluded to a little bit, we also have to consider the turnout demands. So when we talk about turnout, we're looking at external rotation, and that's happening globally in the leg. So some from the hip, from the knee, and then also from the lower leg that we are looking at in ballet, Irish step, ballroom, and also some traditional Indian dance we're seeing as well. So males and females, what makes them different when it comes to the rehab world? So in females, as we said, we're looking at footwear, especially point shoes. So they're kind of up on that toe box in a very extreme end range, 90 degrees of plantar flexion, or if you're in heels. So for ballroom or for some commercial dance work as well, musical theater, Broadway, they might be in more of those heels. For our male dancers, you're looking at a flatter ballet shoe, so they're not up in that plantar flexion range as extremely. They will work in plantar flexion, just not as much. And then their ballroom shoes tend to have a more stable sole as well, rather than the female shoe, which really kind of bends them into this really end range. Choreography wise, females are dancing on point in ballet more often. Some of the contemporary works they won't be, but that is something that they're usually required to do. We're also looking at high repetition turn sequences. So thinking about ankle sprains, posterior impingement, they're often in that 90 degrees of plantar flexion for a long time with a lot of force. The male choreography has its own challenges. So we're looking at them more supporting the female role, but they're going to be on flat feet. So while we may not need to work in this kind of extreme range that the females have to do, we need to make sure that they have a stable base to work from, because they are standing there for a long time, maybe in one place, moving across the stage. To jump down a little bit, they may be lifting or carrying a female dancer in that position. So they're adding now an extra 100-something pounds to their own body weight and what their foot has to carry. Also looking at high amplitude, high repetition jumps, and then demand that puts on the Achilles as well as our foot intrinsics and our kind of foot core system as they're landing from that. So some common foot and ankle injuries in dancers. A lot of these have been touched on already, so I'll try not to spend too much time. But what I hope you can see as a takeaway here is there aren't too many that we would say are only exclusive to male and female. Just based on the demands of dance, we're seeing that they can share a lot of these things that they're coming in with: ankle sprains, Achilles tendinopathies, posterior impingement, os trigonum, especially in our ballet dancers, fifth met fractures. We look at male versus female, that FHL tendonitis or dancer's tendonitis that was previously mentioned, again, being up in that extreme range of plantar flexion can cause some impingement back through that FHL as it passes posteriorly. So we sometimes see that more. Stress fracture, this has been mentioned many times, but not that those are exclusive to our female dancers, but we do want to be considering, is there an energy deficiency issue there, or looking more at a hormonal imbalance. With males, Achilles ruptures we're seeing again with the high demand jumping that they're doing, whether it's the amplitude of the jump or the repetition. And then with that, they're also seeing a little bit more of that anterior ankle impingement from the hard landings that they're doing in those flatter shoes. And again, this is not an exhaustive list. It's not a totally exclusive list, but something else to think about. I think get curious in the rehab world is, what are the roles that your dancers are in as well? We're seeing a little bit more of kind of a crossover of male and female roles in some of the contemporary work and some of the commercial work that's coming out. So not just assuming that your females will be dancing a traditionally female role and a male may not be dancing a traditionally male role. We look at footwear. In ballroom, there's definitely that difference that we were talking about. This female shoe you can see here on the right with the rhinestones, they've got that higher heel, which is going to put them in more of their plantar flexion. And then that is a more flexible sole, which will put them into more of like a toe flexion pattern when we're looking at the line that we're trying to get that foot to make. And then the male shoe is on the left. It's a little bit flatter. It's got a little bit more of a supportive sole. Ballet in the middle, you can see this female dancer, she's dancing on point. So again, achieving that 90 degrees of plantar flexion. The male dancer in the back, he is on flat. So just a little visual for some of the demands there. And then we also look at street and folk and contemporary dance. You just have to ask what your dancers are wearing. They're changing for styles and aesthetics and whatever the choreographer is looking for. So are they in a sneaker? Are they barefoot? Are they in, like, some of them are in really like hard soled thick shoes, depending on what the wardrobe department wants them to be in. So definitely having that conversation with your dancer, with your performer, just to see what they're spending most of their time in. So rehab considerations. This is not an exhaustive list again, but just to touch on some of this, we're looking at the foot core for all of our dancers and performing artists that are coming in. So really focusing in on intrinsic strengthening, making sure that they can control all of those muscles that are giving them that dynamic support to complement the arches, whether they're in and out of a shoe. But also making sure that we're doing this in kind of our closed chain tasks. It's easy to have our dancers sitting there and lifting their toes and all of that, but can they do it while they're jumping and landing, taking off of a reformer maybe? Are we having them do this work and practice their jumping in their footwear, also thinking about the foot core work that you're having them do? And there is a great article that I've cited here at the end about the foot core. If you're more curious about that, it does focus more on runners, just as a caveat. We also want to look at extrinsic strengthening in the foot and the ankle. May not seem like you have to, but you want to check your gastroc and soleus strength for your dancers. They do tend to be more hypermobile, so they can achieve that end range, but we want to make sure that they have the strength to get there. So looking at 20 to 25 good single leg heel raises for our dancers, strengthening posterior tibialis to help again with some of that jumping and landing, anterior tibialis. If you're concerned about like any kind of anterior impingement, looking at our top dancers, making sure they have good control through there. And then our peroneals with concerns of ankle sprain. Proximal stability. So this comes back to the turnout. If dancers and performing artists are weak in their hip turnout muscles or hip external rotators, we can often see those lower leg muscles trying to take over, and that can cause some foot and ankle issues. So checking your single leg balance with eyes open, eyes closed on different surfaces, and then also considering what's going on with their core strength and perhaps in their pelvic floor as far as that relates to tightness down in the feet or compensation down in the feet. Within a session, things that you can think about: ankle dorsiflexion mobilization, if we're concerned about ankle stiffness from a chronic ankle sprain, anterior impingement, making sure that they have enough ankle dorsiflexion in their plies when they're landing jumps is very important. Midfoot mobilization, if they're shoving their feet into these really tight point shoes, making sure that they've got mobility in through there so they can appropriately perform their foot intrinsics is huge. Soft tissue mobility, first MTP mobilization. This can help with some like acute symptoms that we're looking at, but really getting into the strengthening and the neuromuscular reeducation is where the changes are going to come from. You can consider taping and bracing. As Dr. Elson mentioned, again, we can't send them on stage with a lot of that stuff, but for some reeducation, you can use KT tape during your sessions or across sessions. Leukotape can be helpful to reinforce ankle dorsiflexion or navicular control, just to give them more of that feedback. But this is not something that we will always be sending them off in. Just the wardrobe department doesn't always like that. And then footwear. Dr. Smith mentioned some of this earlier, but do we need to make modifications to the shoe? Do we need to be stretching out for a bunion? Do we need to be adding in metatarsal pads if they've got a metatarsalgia? Can we add in little heel lifts if it's like a character shoe, more of a Broadway or play like that, just so that they can have as much support as possible in a shoe to reduce the symptoms until we can get them to a place where they're not flaring that up with any of their performances. So those are the references I mentioned. The McKeon article about the foot core, and that is all.
Thank you so much for a great talk, Dr. Nelson. We're going to move on to Dr. Trupti Tanna talking about sex-specific considerations in rehabilitation of foot and ankle sports injuries. This should be a good one.
Trupti R. Tanna Physical Therapy from Mass General Brigham will present sex-specific considerations in the rehabilitation of foot and ankle sports injuries.
All right. So today I would like to discuss sex-specific considerations in the evaluation and rehabilitation of foot and ankle sports injuries. I have no disclosures. We'll start with a clinical case and then look at sex-specific injury patterns and the intrinsic and extrinsic risk factors, then apply these concepts to screening, rehab, and return to sports decisions. So let's look at this patient case. This is a 30-year-old female endurance athlete and a former collegiate hockey player who presented with left Achilles pain while training for her first marathon. She had previously completed 6 half marathons. This time, her symptoms began after a rapid increase in running volume. Initial radiographs were unremarkable, and so she was referred to physical therapy for Achilles tendinopathy. Despite her symptoms, she maintained a very high activity level, working full-time as a school social worker while coaching field and ice hockey. She also participated in Women's Hockey League, group fitness, spinning, biking, strength and conditioning, and marathon training. Her history was notable for a navicular stress fracture during marathon training approximately 2 years earlier. So at first glance, this appears to be a typical running-related overuse injury. However, I would like to ask, would you evaluate or treat this runner differently because she is a female? Or is it simply another case of Achilles tendinopathy? So before I reveal what happened with her, let's see what evidence has to tell us. The literature suggests that foot and ankle injury patterns differ between female and male athletes. Female athletes are more prone to bone stress injuries, as we heard from Dr. Smith and Dr. Katz, ankle ligament injuries, and osteochondral lesions, whereas males have higher incidences of Achilles tendon injuries. There are several interacting factors that can help us understand these differences in injury patterns between male and female athletes. Anatomically, again, we heard from Dr. Smith that women tend to have wider forefoot, lower medial arches, thinner distal tibial cortices, which may influence load distribution and bone stress injury risk. There are hormonal risk factors, as again, Dr. Katz kind of alluded to, considering the estrogen level fluctuations that can impact ligament laxity and postural stability. Female athletes are also more susceptible to the effects of low energy availability and REDS, which can impair bone health, recovery, and tissue healing. Tendon properties also differ between male and female athletes. Men generally have larger and stiffer Achilles tendons and generate greater plantar flexion forces, which can explain the higher rates of Achilles tendinopathies and rupture in male. Women tend to have more compliant tendons. Finally, biomechanics and neuromuscular control also differ. Studies suggest that female athletes often rely more on proximal kinetic chain during running and landing tasks. They also may demonstrate some concentric dorsiflexion strength weakness, and whereas your males tend to generate greater forces from foot and ankle complex. There are extrinsic risk factors. Historically, women's athletic footwear had been adapted for male design shoes, which did not fully account for differences in foot shape, fit, and traction. Training and exposures also differ. Initially, women had low preseason training, fewer early year sports. During differences in resources and opportunities may also contribute to the variations in conditioning and early season participation in female athletes. So coming back to the case, when I took a more detailed subjective history, the picture changed. She reported a secondary amenorrhea after stopping her oral contraceptives, and she was diagnosed with pituitary macroadenoma. She had to undergo a transsphenoidal surgery. At that point, I realized that this is no longer just an Achilles problem. Her systemic history changed her risk profile and the questions that I needed to ask. So, while I still want to understand the training load, running history, previous injuries, footwear, surfaces, sports demands, I have to expand my history based on the athlete's risk profile. So for female athletes, this may include menstrual health, contraception, nutrition, recovery, and bone stress injury history. For male athletes, I may ask about performance changes, fatigue, recovery, and endocrine concerns. These conversations can initially feel uncomfortable, but providing context and framing them as a routine sports injury questions can help normalize them. The physical examination from a PT standpoint will stay the same. We look at range of motion, muscle performance, functional movements, joint play, palpation, special test. In addition with hip and core, as Emma mentioned, that proximal stability is very important. Once you've addressed those, then you start looking at balance and neuromuscular control. I may pay closer attention in female athletes for quality, movement quality, given the dynamic valgus, the hip control, the rear foot mechanics, and neuromuscular control differences that we saw. In male athletes, because of their higher tendency for Achilles injuries, I might look at more plantar flexor strength and capacity. So communication with the patient's endocrinologist further changed the rehab plan for this patient. Because her amenorrhea was likely related to a higher exercise load, she was advised to have 2 full recovery days per week and avoid consecutive high-intensity cardio days. Those recommendations became a part of her PT plan. So bringing the whole picture together allowed us to better manage her training load, support her recovery, and progress her safely back to her sports, which was running. For me, the key was looking just beyond the Achilles and treating this athlete as a whole. So this is just a quick snapshot, not including all her exercise program, but as Emma mentioned, that this foot core concept, we do need to kind of make sure that we use this for our athletes. In recreational runners, a foot core strengthening program was associated with a 2.4 times lower rate of running injury-related injuries compared with the controls. So adding some of these will definitely help. This is another way of progressing some of those foot core system exercises. We also incorporated some progressive Achilles tendon loading program. We started with the lower load exercises such as seated heel raises, progressed to double and single leg calf raises, and functional strengthening, then advanced to our higher load activities like hopping and plyometrics. The idea was to progress, increase the magnitude and rate of Achilles loading, and ultimately prepare the tendon for the demands of running. We also incorporated Alter-G and gradually reintroduced running, allowing us to control the load on her Achilles while progressively increasing running exposure as her symptoms and tendon capacity improved. And also given like she had that history of bone stress injury, we wanted to be extra careful. So what changed, right? Most rehabilitation principles are the same: progressive loading, strengthening, gradual return to running. What changed is how we individualize this plan based on the athlete's need and risk profile. We continued progressive Achilles loading and strengthening while adjusting her running progression to allow for adequate recovery. Education was expanded not only just to load management in training, but also adding nutrition, energy availability, and REDS. All including like multidisciplinary approach, reaching out to her endocrinologist, referring her to the nutritionist, and talking to her sports medicine physicians. We kind of came up with this plan for her. So takeaway, sex-specific differences matter. They can help us determine what to screen, what to monitor, what to emphasize, how to integrate these other systems, and allowing us to provide more informed, individualized rehabilitation for our patients and our athletes. These are my references, and thank you.
Thank you for a great talk, everyone. Let's have a couple questions for the team, and then we'll try to get a quick case in. Either for Dr. Elson or Dr. Katz, explain how to approach tendinopathy in season, specifically with shockwave, and I think for the audience to kind of get an idea of when can they practice when they're getting these treatments, how many times a week, and is it more of a destructive shockwave that's being done or more restorative?
Sure, I'm happy to start, and then if Dr. Katz has anything to add on, be happy to hear. Now, in general, we really like shockwave because we kind of consider it to be an in-season treatment with no time off required. The one caveat to that is sometimes, even though the actual tendon changes that we're expecting will take months to develop, there can be a little bit of post-treatment anesthesia where patients have a higher pain threshold. And so I do caution them to don't do more than they were doing before, but to continue on the plan that they were having. So there isn't any relative rest required from the actual treatment, but there is the relative rest from whatever injury that we are treating.
And you're doing more radial in season versus focused, or a combination?
Actually, we will do focused in season, but I think that is also a very site-specific question. So a lot of the things where we would be using the focus device are things where people have less weight bearing and might have more restrictions to start with. But for example, like if someone has such a painful Achilles tendon that they're not really walking that much, we're not going to have them jump up and running. But if they've got kind of a mild tenderness and kind of mild symptoms, we wouldn't necessarily change the whatever they're doing. So whatever they were doing before the treatment, they can continue to do during the treatment.
Perfect. Dr. Katz, is there anything new in that realm of shockwave treatments and other? I know I get ads all the time for different types of machines. Is there anything else that's really exciting technology that the audience should know about?
That's such a good question. You'll see a lot of different branded types of shockwave. And what's really important is not the marketing and what looks really pretty, but more so really looking at the energy levels. And that's mostly how you can compare machine to know if you're getting something similar to something else. We often talk about shockwave as one umbrella term. There's really two types. We're talking about radial and focus. So radial being more of that mechanical, that jackhammer massage gun type wave, really being referred to more as a pressure wave as opposed to focus shockwave being the true shockwave. So you might also see people talking about pressure wave and shockwave. And when they're doing that, they are referring to the radial shockwave as pressure wave and the focus shockwave as the true shockwave. The nuances that you're seeing as far as the emerging treatment is much more people looking at how best to combine these together. Is it radial and focus? Is it focused alone? Is it radial alone? And for a lot of the literature that's out there, we're seeing good responses, both combined focus and pressure, as well as one or the other. But the differences within those is how many shocks essentially or pulses are being given. And so it's really knowing if you're going to have one or the other, making sure it's the right amount. The other thing that's really emerging in our literature is looking at how best to combine all of our treatments. So, is it shockwave plus platelet-rich plasma? Is it shockwave plus something else? How best to really mix and match all of these as opposed to so much new. I think it's more combining what we have already and understanding how best to make the most of it.
Perfect. Thank you. For Dr. Nelson, I have a question about any specific therapy exercises for treatment of cuboid subluxation. I have patients all the time in my office telling me that they're subluxing their cuboid. I'll throw them on the x-ray and try to get it to move, and it doesn't. But they definitely feel like there's certain treatments that work better. So on a surgical side, there's not really like a specific thing that we see with this, but I know patients talk about it. So what do you do for these people?
Yeah, I don't know that there's a specific exercise, but I think when we're looking at kind of globally planning rehab for this, you definitely want to look at calf strength, lateral ankle strength, but also going up the chain into what's happening in the hip as far as turnout, because if they are pulling a lot of their turnout from that lateral ankle, they may be pulling on that cuboid over and over and over again, right? So how can we reduce that strain and looking up higher in the chain there? So, a lot of work in single leg, focusing on the hip external rotators there, making sure they've got that stability higher up. So, and then you just find the exercise that your patient responds best to. It may be a little bit of trial and error, but adding in some lateral ankle stability in single leg stance, or are we working in a bridge, holding some of that pelvic stability while then adding it's in a heel raise or something. So you just find kind of that sweet spot, but you definitely have to be looking higher up the chain.
And there's a lot of manual manipulation on the foot, like osteopathic manipulation or massage or chiropractic type work that goes for that.
It could be
just the exercises up the chain.
It could be. I mean, you can definitely look at if they feel like that cuboid's not where it should be, you could look at trying to get that back into a better position. Manual therapy to address any soft tissue restrictions, myofascial pain, but really looking at stabilizing what's happening throughout the foot and the ankle so that it doesn't continue to come out of place.
All right, one final question for Trupti. How do you load modify these athletes that basically have events every night? Like, how do we do that?
That's a great question. And it's very interesting, like, especially if you're talking about from like say tendon standpoint. I mean, I tell my patients, I will give them like a pain scale, if you will. I'll tell them like, okay, if you start your day and your pain is at like a 4 or 5, you need to kind of just, backtrack. Think about things you did 24 hours ago, maybe make a list of it. And then that day can be like your off day. Take it easy. Make sure I provide them strategies with like pain relief, either ice it, roll it, massage it, let get that pain level down to about, say, 1 or 2 on 10. And then we start from there. And I tell them we need to have that clean slate before we can start progressing and working towards whatever their goals may be. Once they start their day and they're at a 1 or 2, I'll give them a frame of reference in terms of like, okay, we need to either that, you were working at, say, 2 miles of a running speed or like your walking speed or things like that, then you're kind of trying to progress from there. And we kind of give like, continue with this for about a week, and then we progress again. Continue with this for another week, progress again. If you're having that kind of periods of where you dipped in, think about what you did 24 hours ago, write it down, let me know what it was. We'll look at your mechanics at that point and we'll see what happened. And so I don't let them go above a 5 on 10 at any point in time. So that way they're not kind of backtracking and seeing what happened and what caused it. So it's like just giving them a really tight frame of reference is how I kind of manage them so that we don't get them flared up.
Perfect. Well, we're at 5 o'clock. I have a case, but I don't think we can do it, right? We just share it. We can go 5 minutes. All right. Let me try to share because. All right. All right. So just a case I have of a patient with left sesamoid pain. She started having pain while dancing for a collegiate dance team, and 3 months later it worsened. She tried some orthotics and used a boot. Interestingly, almost never when patients have sesamoid pain are they actually offloaded in their boot. So one of the things we see in the office is that with overloading, their first metatarsal plantar flex and actually push the sesamoid to make an indentation in the boot. So this actual athlete had that. So if she maybe had been offloaded, may not been at this point. She was doing some therapy and had 2 cortisone shots, which weren't done in her image. And then she was having pain with regular walking, and 4 out of 10 pain. It was achy, constant, and sharp. These are her x-rays. So what we see sort of looking at this is there's fragmentation of her lateral sesamoid. Her medial sesamoid actually doesn't look all that bad on the x-rays, but is a little different. And overall alignment, she's not in an excessive cadence position or anything where it was like obvious that she was overloading her sesamoids. So what we see on the MRI is there's avascular necrosis of the lateral sesamoid. And just similar medial sesamoid changes, not as bad. So what's the sort of therapy approach on sesamoid case, either for Dr. Tanna or for Dr. Nelson? What do you guys like to do for these?
Looking at those foot intrinsics, but I think also looking into plantar flexion mechanics. Is there an over recruitment of toe flexors going up into plantar flexion, leading to some of that kind of irritation on the bottom of the foot? Sorry, did you say this? What sports or recreation was this patient involved?
It's like a dance team, collegiate dance team.
Yeah. So I think again, looking at hip and core, what's happening if she's landing certain jumps, taking off, what those mechanics are looking like, and making sure that she's got good stability higher up. Trupti, I don't know if you have any other thoughts.
The great, first toe mobility, first MTP mobility and things like that, making sure that she has that. And sometimes like offloading or taping or things like that can also help initially to calm things down.
What's the biologic or shockwave approach that you guys are doing for these sesamoid avascular necrosis cases? I send them all your way.
I've done a few shockwaves on these, and typically good response, but it takes a lot more treatments than you would see with other regions, and a lot more rehab. I feel like they just take a really long time, but eventually the radial shockwave, the focus shockwave to the sesamoids, and then the radial in the posterior kinetic chain and any other compounding areas that we think are affecting the area. And it's interesting, there is one case in the literature of PRP for this in a dancer. And when I talked to the team that treated them, they had good results. When I talked to the PTs on that team, they think it was shutting the patient down and having good dance rehab was the actual thing that helped the most, and probably a combination of everything. So I think having that team and making sure that no matter what biologics we're doing, that we're getting the good rehab at the same time, because otherwise, if we're not fixing the biomechanics, it won't improve.
Side, I think Jeremy would agree that be careful about taking sesamoids out. I have seen, usually we talk about cock-up deformity, or when you take out both sesamoids, which is an obvious no-no. But when you take out one sesamoid, you can still get cock-up deformity. I actually just had a lady in the office that had sesamoidectomy like 20 years ago, and so was total cock-up deformity, and she just had a medial sesamoid removed. So it's something you have to be mindful of. So it's not a willy-nilly procedure for me, at least. Like, I want to make sure that patients have exhausted all types of treatment before doing it. So this is actually one of the cases where we did do a isolated lateral sesamoidectomy from the plantar approach. And I just made her non-weight bearing for 2 weeks. And when I do these, because it's really a plantar plate repair in addition to a sesamoidectomy, I usually will kind of do a toe spike up for 2 weeks to really sort of contract the plantar tissues to allow them to heal up before we start stressing them. And then when I have them in the boot, I use a sesamoid recess pad to offload the area going further. I thought she was back to sport quickly, practice at 10 weeks and competition at 4 months. But I'm also seeing it with a very well-known podiatrist who's written a lot on running injuries and sort of chronic clavicular issues as well, has reported that it's 7.5 to 11 weeks, and there's no difference between sides on these. But during the rehab, I think this is not a surgeon just takes the bone out, but it's really all about the rehab. So whether you approach it, lateral sesamoid is difficult to approach from dorsal on patients that don't have a bunion deformity. It's hard to get down low, and when you do a plantar approach, the scar is oftentimes very painful for patients. So I always weigh that when I talk with them. We're really just trying hard not to do everything possible other than surgery on these. And it's very frustrating for the athletes. And so, Trupti, what are your therapy goals to have someone return to dance with this? Specifically, like, we have like an ECL criteria for getting people back to sports, but what do we do? What are we looking for? People ask me in the office, and I say, well, kind of like whatever Trupti says.
Of course, maximizing range of motion, making sure that there is no pain at like the normal activities that they're normally doing. Like, if it's a runner, I'll make sure that they can walk as much as they want on all different surfaces without having pain and discomfort before I can kind of start them to progress with running. As Dr. Nelson also mentioned, is like, that proximal core, proximal stability, make sure that they're getting all that biomechanically, that they're looking good. I tell people, like, you could have normal alignment, but if you're loading it on an abnormal tissue, you're going to have pain. You will have an abnormal alignment and you're loading it on a normal tissue, you'll have pain. So it's like we have to make sure that they both are maximized to the best. And so I make sure that those things are covered before I would kind of progress them with anything. And then, training them plyometrics, like double leg first before single leg, balance with static balance, then dynamic balance, and then sport specific movement patterns, like whatever they are, I'll have them, okay, let's do it here. Let's see how you look. Let's see what happens, and kind of going it that way. I don't know if Dr. Nelson would have anything else to add.
I think we could do a whole other hour discussion on a return to dance protocol for any injury. But yeah, of course, you want to make sure that their ADLs are pain-free. But looking at some tests that we're looking at in the dance-specific world are like your hip airplane tests for that single leg balance, the pelvic control. Can they do 20 to 25 single leg heel raises on that side with good alignment and no pain? If they can't, then that's like a full stop. We have to make sure that that's back. getting them on the reformer, perhaps the Pilates reformer, to look at alignment and some of this jumping and all of that. So unfortunately, there's no set, like there's so much research. Again, we talk about like ACL return to sport. We don't really have that for dance yet. So we're looking at what specific movement patterns do we know that our dancers have to be able to do, and can they do them well? And they have to do them on a flat foot on stable surfaces before we look at the jumping, the plyometrics, getting them in any of that specific footwear or anything like that. So, I mean, if I had to pick a couple, I would say like 5 single leg deadlifts or single leg RDLs with good control, or a hip airplane test if you want to look that up. The 25 single leg heel raises each side with good alignment. And then like a forward or a lateral step down off of a box, I usually look at. If they can do like 5 to 10 of those with good alignment, then I'm usually okay with starting them on some kind of like return to jumping, return to impact program.
And also start excursion balance test, yes.
Perfect. And then orthotics for day-to-day use and topical pain creams, but anyone else have any adjuncts that they do for these types of patients to get them back?
Yeah, I think looking at footwear when they're not in their dance footwear, just so we can support them and get offloading as much as possible. So we usually have a conversation about that.
That's perfect. And then any scar-specific treatments that you guys have found helpful for plantar scars and dancers, which are not ideal? I'll occasionally refer people for Shockwave for it, but otherwise we just have them sort of do a lot of aggressive soft tissue massage and silicone taping, but they're always hit or miss, and that can sometimes be more painful than the sesamoid. That's what I tell them. So, but yeah, no, that's I think a great webinar, and thanks for everyone for joining. And to Arthroschool, we appreciate it.